Welcome back to chapter 65, part 2. This is one of the most important concepts in healthcare, talking about breast cancer in general. Okay, so let's talk about breast inflammation and infection. Breast abscess. Non-lactational breast abscess can occur peripherally from the nipple or in the vicinity of the areola. These types of infections are often found in patients 18 to 50 years old who have diabetes, clogged sweat glands, acne, or trauma to the area. Treatment includes broad-spectrum antibiotics, ultrasound-guided aspiration, and/or incision and drainage. Remember that you are going to come across my comments um, with the statements like, "That's good to know," and meaning that these concepts could be included in the final or in the quizzes. None of the questions of your final and quizzes are out of this book. I made sure 100% guarantee all the questions are coming from your book and everything that I am presenting in the lectures. Okay, um, I personally review all the questions one by one and make sure everything is included in these chapters. I can take questions from other resources, other books, but always you will find the answer in your chapters, in your book. Okay? Okay, mastitis. Mastitis, inflammation of the breast that may be accompanied by infection and pain, is often associated with lactating and breastfeeding women. However, it can occur in women who are not lactating or breastfeeding. This condition is more common in women who smoke and in women who have nipple piercing, where bacteria can enter through a milk duct. Remember, I told you need to be very comfortable with what is a duct, where is it located, what is the lobule, and where they are located. Treatment options depending on the specific type of mastitis include antibiotic therapy, the same as with breast abscess, steroid therapy, or waiting. Women with non-lactational mastitis have a higher risk of breast cancer than women without non-lactational mastitis. Let's move to cellular regulation concept, exemplar breast cancer. Cancer is a common problem of impaired cellular regulation. Impaired cellular regulation. Cancer of the breast begins as a single transformed cell that grows and multiplies in the epithelial cells lining one or more of the mammary ducts or lobules. It is heterogeneous disease having many forms with different clinical signs and symptoms and varying responses to therapy. Some breast cancers present as a palpable lump in the breast, whether others show up only on a mammogram. That's why it's important to do your cell breast examination and yearly mammogram if you are in the range uh, um, of woman and your age is within the range of this test, because it's the only way. Breast cancer at this point is very treatable if it's diagnosed at an early stage. There are two broad categories of breast cancer: non-invasive and invasive. Invasive. As long as the cancer remains within the mammary duct, it is referred to as non-invasive. Here comes the concept I'm telling you to be comfortable, the duct. So when the cancer is within the mammary duct, it's non-invasive. The more common type of breast cancer is classified as invasive, and this is the most common, right? This type grows into surrounding breast tissue. Metastasis occurs when cancer cells spread beyond the breast tissue and lymph nodes via the blood and lymphatic system to distant sites. The most common sites of metastasis are brain, bones, liver, and lungs. I always remember this, my BBLL, my brain, bones, liver, lung, my BBLA. But breast cancer can spread to any organ. The course and treatment of metastatic breast cancer is related to the site affected and the level of functional impairment. Um, let's go to the non-invasive in situ, in the ductal, mammalian ductal, right? Breast cancer. Ductal carcinoma in situ is an early non-invasive form of breast cancer. It's an early, so the diagnostic must be early in order to prevent metastasis. In ductal carcinoma in situ, cancer cells are located within the duct and have not invaded the surrounding fatty tissue. Because of more precise mammography screening and early detection, the number of women diagnosed with DCIS has increased. Currently, there is no way to determine which DCIS lesion will progress to invasive cancer. There's no way to know the behavior of this, and which one will remain unchanged. However, evidence does confirm that DCIS can be a precursor to invasive cancer. I understand with this statement that currently there is no way to determine which disease will progress to invasive cancer. That so far, the treatments cannot guarantee 100% the recovery, right? Because we don't know how this disease is going to progress. We cannot guarantee. But what we can do is to focus on prevention. Less salt, less caffeine, less intake of red meat, right? Um, reduction in adipose tissue. Reduction in adipose tissue. We know that obesity is an inflammatory process. So if we keep the patient in an optimal weight, we can try, right, to have this disease. We can prevent this. Also, we can test for genetic factors, but even with genetic, if you do the proper nutrition and exercise and you don't get into bad habits like smoking or alcohol, you have a healthy life, right? You can prevent, in general, most of the conditions. This uncertainty can cause anxiety and conflict regarding treatment decisions in women diagnosed with DCIS, as I was telling you. Another type of non-invasive disease is lobular carcinoma in situ. Lobular carcinoma in situ. The cells look like cancer cells and are contained within the lobule milk-producing glands of the breast. LCIS is not considered cancer, but does increase the patient risk of developing invasive breast cancer, like DCIS. Exactly the same. The only difference is one is in the mammary ductal glands, and the other one is lobular glands. It is usually diagnosed before menopause in women 40 to 50 years of age. Traditionally, LCIS is treated with close observation only, but surgical excision is an option. Okay, so there you go. Invasive breast cancer. Now we're talking about invasive. Before we were talking the non-invasive, ductal carcinoma and lobular carcinoma. Now we are going to the invasive. The most common type of this cancer is invasive ductal carcinoma. As the name implies, the disease originates in the mammary ducts and breaks through the walls of the ducts into the surrounding breast tissue. Once invasive, the cancer grows into the tissue around it in a irregular pattern. If a lump is present, it is felt as an irregular poorly defined mass. As I explained in the first part of chapter 65, the difference between the benign and the malignant breast cancer is that benign has a regular oval shape and is freely movable. In terms of malignant breast cancer, the shape is irregular and is fixed. Okay? As the tumor continues to grow, fibrosis, replacement of normal cells with connective tissue and collagen, develops around the cancer. Typical skin dimpling. It's not dumpling. Typical skin dimpling that is seen with more advanced disease is present. Another sign sometimes indicating late stage breast cancer is an edematous thickening and pitting of breast skin called peau d'orange, orange peel skin. And here is a picture how skin dimpling looks like, okay, as a result of fibrosis or breast cancer. And here you can see the breast edema giving the skin an orange peel, peau d'orange appearance. This is a very dramatic picture. Sometimes the changes in the color of the skin is not as dramatic, but you can identify the orange peel skin, right? It's easy to identify that. A rare but highly aggressive form of invasive breast cancer is inflammatory breast cancer, IBC. It is characterized by diffuse erythema and edema. Patients typically report breast pain or a rapidly growing breast lump. Is the one in the picture. Other types of breast cancer, Paget disease of the nipple is a rare breast cancer that occurs in or around the nipple. Although more common in women, it can also occur in men. Okay, so let me present first the triple negative breast cancer, as the cancer most people the most scared about this is this triple negative breast cancer. Lacks expression of the estrogen receptor ER, progesterone receptor PR, and human epidermal growth factor receptor HER2. This type of breast cancer grows rapidly and is often found in women with BRCA mutation who are premenopausal. So, as I said before, nothing is written, nothing is absolute in this type of disorders, because I've seen women that are not premenopausal, right? Some women are not having the BRCA mutation, but they are presenting with this type of cancer. African American women are at higher risk for TNBC than women of other races. Let's watch this video. Guys, I am sure you are going to be very happy at the end, even though it takes a lot of time for this presentation, but you're going to be very happy to be able, comfortable knowledge to know these concepts and to help any family member with these conditions, okay? Triple negative breast cancer.
Triple negative breast cancer, the facts. Breast cancer is the most common cancer among women. More than 1.67 million women are diagnosed worldwide each year. 15% of all breast cancers are classified as triple negative, known as TNBC. Incidence of TNBC is more common in women under the age of 40 to 50, compared with other forms of breast cancer. Breast cancer is generally classified based on the presence or absence of 3 receptors known to fuel most breast cancer tumours: estrogen, progesterone, and HER2. A diagnosis of TNBC means that the tumour does not exhibit any of these three known receptors. Some TNBC cells also express a protein called PDL1, which enables cancer cells to avoid the immune response. Knowing the signs and symptoms of breast cancer is essential for early diagnosis and treatment. The key local signs of breast cancer may include a hard lump developing in the breast or armpit, a change in the size or shape of the breast, such as indentation, particularly prominent veins or skin erosion, changes in the skin, such as hardening, dimpling or bumps, redness or an orange peel-like appearance, changes in the nipple, such as retraction, the secretion of unusual discharge or a rash. Risk factors for developing breast cancer include BRCA gene mutations, family history, obesity. A number of factors have been shown to increase a woman's risk of developing TNBC specifically, although further research is required to fully characterize who is most at risk. Women who have never given birth have a 40% lower risk of TNBC than those who have experienced a full-term pregnancy. Little to no breastfeeding and high BMI are associated with increased risk of TNBC. There is an increased likelihood of distant cancer recurrence in TNBC compared with other subtypes. Metastatic TNBC is the most advanced stage of the disease, as the cancer has spread beyond the tissues of the breast to other parts of the body, most likely to the brain and lungs. Currently, chemotherapy and non-HER2 targeted treatments are the mainstay of treatment for metastatic TNBC, although clinical practice patterns vary worldwide.
Thank you so much for this video. So to make it clear, if the tumor has the receptor, the estrogen receptor, the progesterone, and the human epidermal receptor, therapies are easier, right? And you can attack whatever is needed. But without the receptors, it's triple negative. Without the receptors, basically the therapy is based on the experience of the hematology oncology. Plus, this tumor, as the video explained, has a PDL1 or 2, which impedes the immune system response. So it's not receptive to the immune system response. Okay, so that's why this cancer is, I would say, the worst. Okay, and HER2 is short for human epidermal growth factor, describes a protein that plays a role in normal breast cell development. Okay, male breast cancer is rare and accounts for less than 1% of all breast cases. Risk factor for male breast cancer includes previous radiation, family history of breast cancer, BRCA1 and 2 mutation, diabetes, alcohol use, and liver disease, testicular disorders, and obesity. Again, obesity is present in most of the conditions that we have studied in this semester. Men usually present with a hard, painless subareolar mass. Gynecomastia may be present. Other symptoms include nipple discharge, rash around the nipple, inverted nipple, ulceration or swelling of the chest, and possible swollen lymph nodes. Because men usually do not suspect breast cancer, they often ignore the symptoms and postpone seeing their primary healthcare provider, right? And don't forget about spironolactone, aldactone, that is a potassium-sparing diuretic that usually causes gynecomastia, okay? Genetic predisposition is a stronger risk factor for younger women than older. Younger women frequently present with more aggressive forms of disease. They are usually diagnosed at a later stage, and they have triple negative breast cancer and must receive an aggressive treatment. in younger women, right? Eggless examination. Let's do this question. When caring for 4 patients, which individual does the nurse identify as being at the high risk for development of breast cancer? A 33-year-old male with gynecomastia and obesity, 45-year-old female whose mother has breast cancer, 60-year-old male whose father died from colon cancer, 72-year-old male who was treated for breast cancer 3 years ago. So the number B, letter B, is the response. The rate of breast cancer in African American women younger than 60 years is higher than for others in that age group. African American women are also 40% more likely to die from breast cancer than white women. This is very sad. Um, this is found in America. Indians, African American, and Hispanic women were also likely to present with more aggressive breast cancer that is harder to treat, such as the triple negative breast cancer. African American women have the highest risk for triple negative breast cancer. Incidence and prevalence. 1 of every 8 women in the United States will develop breast cancer in her lifetime. 1 of every 8. It is more common cancer diagnosis in women. So if you go to a party or you meet your friends from schools and you go to have a lunch together and you're 8 people sitting at the table, one of you is going to have breast cancer. Breast cancer is the second leading cause of cancer death in women aside from skin cancer. So we are 29 students in the classroom plus the professor is 30 people in the classroom. So it's 30 people divided by 8 is going to be 324. It's almost 3 people in the class, probably 4 will have breast cancer just in our class. Okay. Um, Etiology and genetic risk. That's why it's so important, this chapter. Take the time, review it, not only for the exam, but for your life and your patients and your family. Increased age is the primary risk factor for developing breast cancer in most women. In both men and men, several other factors are known to increase the risk for developing breast cancer, such as family, genetic, we spoke about that. Early menarche and late menopause. So if you got your first period, let's say at 11, but you're starting menopause at 55. Why is that so risky for breast cancer? Because you are exposed to estrogen for a longer period, from your 11 to your 55. Okay? These factors are not modifiable. Modified risk factors include but are not limited to postmenopausal obesity, so you can lose weight, physical inactivity, use of combined estrogen and progestin postmenopausal hormonal replacement therapy, alcohol consumption, and lack of breastfeeding. Lack of breastfeeding. Okay? And that's good to know. This is good to know. Patient-centered care. Mutations in several genes such BRCA1, BRCA2 are related to hereditary breast cancer. People who have specific mutations in either one of these genes are at increased risk for developing breast cancer and ovarian cancer. Okay. According to the American Cancer Society, some inherited genetic mutations linked to ovarian cancer include BRCA1 and 2, PTN, STK11, MUTYH, and the other ones. Okay, so it's good to do the genetic study. Health promotion and maintenance guidelines have not been recommended for screening men in the general population because breast cancer in men is rare. In addition to other screening and assessment methods, the National Cancer Institute offers a breast cancer risk assessment. And this tool can be used by a healthcare professional to estimate the risk. Teach women that no single method for early detection of breast cancer is effective when used alone. No single method for early detection of breast cancer is effective when used alone. The best approach for average risk women is a screening mammogram, clinical breast examination, and breast self-awareness. So you have to do them all. You have to do them all. Risk factors for breast cancer: the female gender. Of all breast cancers, 99 occurs in women more than 65 years old. Risk increases across all ages until age 60. Remember, the estrogen that is coming for adipose tissue, not from the ovaries. That's why after 65, your estrogen is coming from the ovaries, it's coming from the adipose tissue. You gotta lose weight, you need to exercise. Genetic factors: inherited mutation of BRCA and BRCA2 increased risk. History of previous breast cancer in the family. Okay, breast density, atypical hyperplasia, family history. Having a first degree relative with breast or ovarian cancer increases the risk. Not colon cancer. Okay, it's breast or ovarian. Ionizing radiation: who receive frequent low-level radiation exposure to the thorax have an increased risk, especially if the exposure occurred during periods of rapid breast formation. High postmenopause bone density. Talking about ionizing radiation. Okay, I have many patients that they are refusing. They have fibrocystic changes, they have fibroadenoma, and they know about the exposure to radiation. So they refuse to do the annual mammogram because of the radiation. So they are doing the follow-up every 2 years, every 1.5 years. And I mean, they got the point, right? They got the point. Even though we know mammogram is a low level radiation compared to the 3D mammogram, but you have to understand the patient's decision. You provide all the knowledge, all the concepts, and they are the one taking their decision, right? They are the ones who are telling you, I don't want to be exposed to mammogram every 6 months. If you find, if the radiologist is making that recommendation, sometimes they make that recommendation follow up after 6 months, after 1 year. So they got the point. Recent oral contraceptive use: when there is a slight increase in breast cancer risk in women taking oral contraceptives, the risk returns to normal 10 years after stopping the pill. Obesity, alcohol consumption, high socioeconomic status, high risk for breast cancer. Why? Breast cancer incidence is greater in women of higher education and socioeconomic background. This relationship is possible related to lifestyle differences such as later age at first birth. So we talk about the nulliparity, the lack of lactation, right? Risk, especially the lack of lactation. So women with high education and socioeconomic background, they want to become a mother not in their 20s, as it used to be before, but right now, late 30s, for the beginning of the 40s, some of them. And in order to get pregnant, they are going through hormone treatments, right? So think about that. Jewish heritage. Women of Ashkenazi Jewish heritage have higher incidence of BRCA2 and BRCA1 genetic mutations. That's something to consider, right? Um, Mammography. In 2015, the American Cancer Society updated its breast cancer screening guidelines, which now recommend that women at average risk of breast cancer begin annual screening mammography at age 45 up to age 54. That's the American Cancer Society. Women age 55 and older may switch to mammogram every 2 years or continue annual screening mammograms if they choose to do so. So it's up to them. I want to do it every 2 years. I want to do every year. I want to do every three. You're going to come across women that are protecting, they think they are protecting themselves. Or maybe they do. Maybe they are right. Canadian guidelines for mammography differ from those of the United States. No routine mammography screening is recommended until women reach 50 years of age. After 50, the recommended guidelines vary slightly across organizations, but generally recommend that women after 50 get a mammogram every 2 to 3 years. There you go. Until age 70 to 74. Now with the internet and access to different information online, patients are, I don't want to do the mammogram because in Canada, for example, they are doing this every 3 years after a certain age. So they start comparing the type of treatment in different parts of the world and they do their research. Okay, breast self-awareness, self-examination. Let's watch this video to see how is this done properly.
Breast cancer is the most common cancer affecting women in Singapore. It is estimated that 1 in 14 women before the age of 75 will develop breast cancer in her lifetime. You can keep a lookout for breast abnormalities, starting with a visual examination of your breast with your arms by your side in a neutral position in front of a mirror. Look for any of the following: changes in the shape and size of one breast, dimpling or puckering of the breast skin or nipple, persistent rash or change in the skin around the nipple, nipple inversion, retraction, bleeding or unusual discharge, skin redness or soreness of the breast, accentuated veins of the surface of the breast, unusual swelling of one upper arm. Adopt the following 2 positions. Raise your arms above or behind your head. Press your hands on your hips and tense your chest muscles. These 2 positions allow for a closer inspection of the following: changes in the shape and size of one breast, dimpling or puckering of the breast skin or nipple. To feel for changes in your breast, underarm and collarbone areas more accurately, do so by lying down because the breast tissue spreads out evenly across your body. This makes it easier to feel for lumps. What you should look out for: a lump, swelling, or thickening in the breast or underarm area, any enlarged lymph nodes at the underarm and above the collarbones. Lying down. How to examine your breasts when lying down. Elevate your right shoulder by placing a folded towel or pillow underneath. Extend your right elbow outwards and place your right hand under your head. Use the pads of your 3 middle fingers and apply pressure to feel your breast tissue in a circular motion. Use 3 varying pressure levels, light, medium and firm, to feel for all the breast tissue from the skin level to tissues closest to the muscles and ribs before moving on to the next area. Examine the whole breast systematically in a clockwise or anti-clockwise direction. Press down over your nipple with 3 varying pressure levels in a circular motion. To check for lumps at your underarm area, put your arms by your side. Start in the hollow of your underarm and move towards your breast, making overlapping small circular motion. To check above the collarbone, use light pressure and move in a circular motion. Repeat the same steps on your left side. How often should you perform breast self-examination? The best time to perform a self-examination is about a week after the start of your menstruation. It is more effective to perform on the same day of each month if you are no longer menstruating, pregnant, breastfeeding, or have breast implants. It is important to understand that breast self-examination can complement breast cancer screening, but it is not a substitute for it. Most lumps or changes in the breast are not cancerous, but as a precaution, it is advisable to consult a doctor as soon as possible.
Thank you so much. The video is referring to 1 in 14 people is being diagnosed with breast cancer in Singapore. 1 in 14 women, right? And here in US is 1 in 8. I'm sure it has a relation with the nutritional and the pattern of exercise. Okay, you have to do both self-breast examination and mammography. Okay, don't forget the mammography. So here they are explaining how to do the breast self-examination. And here the clinical breast examination is performed by advanced practice nurses or other healthcare providers, usually the nurse practitioner or the hematology oncology. And it's going to check not only the breast but the lymph nodes in the axilla, right? Another NCLEX examination, double check that. Option for high-risk women. Those with a personal history of breast cancer are at risk for developing a recurrence or a new breast cancer. Women with known BRCA1 and BRCA2 genetic mutation have a lifetime risk of developing breast cancer by age 70 of about 55% to 65% and 45% respectively. In addition to annual mammography and clinical breast examination, high-risk women are recommended to have an annual breast MRI screening. Close surveillance may begin as early as 30 years, but evidence is limited regarding the best age at which to start. For women with high risk for breast cancer development due to family history, such as cancer in a member or sister, it is recommended that cancer screening begin at the age that is 10 years younger than the age at which the affected cancer patient was initially diagnosed. So if a patient has a sister that got diagnosed with breast cancer at 30, let's say, that patient needs to start the screening at 20. If a patient has a mother who got diagnosed with breast cancer at 60, the patient needs to be need to start examination and screening at 50. Okay, to make it more understandable. Other options currently available for reducing a woman's breast cancer risk are prophylactic mastectomy, preventive surgical removal of one or both breasts, prophylactic orectomy, removal of the ovaries, and chemopreventive drugs. Even though women may decide to have a prophylactic mastectomy, there is a small risk that breast cancer will develop in residual breast glandular tissue because no mastectomy reliably removes all mammary tissue. It's very important. Very important to know that, as I said, nothing is written, nothing is absolute. You have your Angelina Jolie, she removed both breasts, she removed the ovaries, I don't know what else she removed. But there's a small risk that breast cancer will develop in residual breast glandular tissue because no mastectomy reliable remove all mammary tissue. And she got prophylactic mastectomy, I think. Women undergoing prophylactic or oophorectomy, that's the ovaries, right, will likely experience menopausal symptoms, although some estrogen remains in body fat tissue. Chemoprevention drugs such as tamoxifen, we spoke that this drug is estrogen modulator, reduce breast cancer recurrence but carry other risks such as blood clots and endometrial cancer. Think about that. So the men who are taking tamoxifen, okay, can develop blood clots. Women taking tamoxifen to prevent recurrence can develop blood clots and endometrial cancer. Okay, let's make a break here and then we come back with part 3 of chapter 65.